All right, we are bypassing all the fluff today and stepping directly into the test day cognitive pathway for Step 2 CK endocrinology. This explainer is built purely on clinical decision logic. We're going to train your brain to react to endocrine scenarios with exact, algorithm-driven next steps. No hesitations, just the correct answers. Okay, let's get right into it. Before we even look at a specific pathway, you've got to internalize the absolute golden rule of endocrinology. Biochemical diagnosis always comes before imaging. Literally always. If you suspect an endocrine disorder, your first step is lab work. If the labs confirm it, then, and only then, do you image. Imaging is completely useless and honestly often misleading without that biochemical confirmation. Why? Because incidentalomas are everywhere.
Okay, let's pause for your first test day scenario. A patient has a prolactin level of 250 nanograms per milliliter. What is the diagnosis?
It's a prolactinoma. Boom. A level over 200 is virtually diagnostic for a prolactinoma. And this brilliantly illustrates our first algorithm. Look, before jumping to an MRI, you absolutely must rule out secondary causes, most notably pregnancy. Once those secondary causes are cleared, then we get the MRI of the pituitary gland. If that MRI shows a macroprolactinoma, which is 10 millimeters or larger, or if there are neurologic symptoms, we treat medically first. Dopamine agonists, like cabergoline, are your go-to here. Surgery? That's reserved for folks who have persistent symptoms, fail the medication, or just can't tolerate it. And what about asymptomatic microprolactinomas under 10 millimeters? We do nothing. No treatment.
Let's move to the next pituitary decision tree. Pause for a second. You're looking at a patient and you suspect acromegaly just based on their physical features. What is the absolute best initial screening test?
The answer is an IGF-1 level. Now, what's really fascinating about this logic is the sequence, because growth hormone is pulsatile. It spikes and drops, meaning a random growth hormone level is basically useless to you. So we use IGF-1 as our stable screening biochemical marker. If IGF-1 is elevated, well, actually hold up, don't image yet. We must perform the confirmatory biochemical test first, which is the oral glucose suppression test.
Let's push this logic one level deeper down the tree. Pause again. A suspected acromegaly patient has inadequate growth hormone suppression after taking oral glucose. What is your immediate next step?
Now you get the MRI of the brain. We finally have our biochemical diagnosis, right? So now we image to find that pituitary mass. But here is the critical test day pivot. If that MRI reveals a completely normal pituitary gland, your algorithm isn't over. You've got to evaluate for extra pituitary causes, specifically ectopic growth hormone or GHRH secreting tumors.
All right, shifting our focus over to fluid and sodium balance pathways. Pause. A patient with SIADH develops severe hyponatremia and active seizures. What is the required treatment?
Hypertonic 3% saline. No hesitation. When you look at this flowchart, you must distinguish between mild and severe SIADH. This patient has seizures, meaning they have central nervous system encephalopathy. That dictates acute management with 3% saline to rapidly but safely correct the sodium. This sharply contrasts with milder moderate SIADH management, where we strictly rely on fluid restriction, sometimes combining it with salt tablets. Keep in mind that 3% saline must be administered super carefully to avoid osmotic demyelination syndrome.
So what about the exact opposite problem? Pause. To evaluate suspected polyuria, what process urine output threshold over 24 hours actually confirms the diagnosis?
It has to be greater than 3 liters. If it's less than 3 liters, it isn't true polyuria, you're just working up urinary frequency. But if it is greater than 3 liters, this algorithm dictates we look straight at the urine concentration. We split the pathway right here. Dilute urine points to a water diuresis, meaning primary polydipsia or diabetes insipidus. Concentrated urine, that points to an osmotic diuresis, meaning there is increased solute excretion going on, like glucose and diabetes mellitus.
Let's force the differential diagnosis based purely on sodium patterns. Pause. A patient with confirmed polyuria and dilute urine has a profoundly low serum sodium. What is the diagnosis?
Primary polydipsia. The crucial point on this table is the serum sodium level. It's the key that unlocks this whole differential. In primary polydipsia, the patient is drinking massive amounts of water, driving their serum sodium down into hyponatremia. Contrast this sharply with central diabetes insipidus. In central DI, they are losing massive amounts of free water due to a lack of ADH. And because of an impaired thirst mechanism, their serum sodium is high, often way over 150.
Section 2.
hyperthyroidism and thyroid nodules.
Let's launch into the highly tested thyroid nodule workup. Pause. You feel a thyroid nodule on physical exam. What are the two absolute first diagnostic tests you must order?
A TSH level and a thyroid ultrasound. Literally, do not pass go, do not order a scan yet. The TSH level dictates the entire downstream path of this specific algorithm.
Let's drill down into the specific low TSH branch of this algorithm. Pause. The patient's TSH comes back low. What is your next diagnostic test?
Radioactive iodine scintigraphy. See, a low TSH means the thyroid is hyperactive. The scintigraphy tells us if the nodule itself is the source of that activity. If the nodule lights up, it's a hyperfunctional hot nodule, and the algorithm routes you straight to hyperthyroidism treatment. Hot nodules are very rarely malignant. But if it's hypofunctional, a cold nodule, the risk of cancer is definitively higher. For cold nodules, the algorithm routes you to consider a fine needle aspiration, or FNA, depending on the nodule's size and its ultrasound features.
Let's lock in some specific pharmacologic side effect knowledge for Graves' disease. Pause. Which specific hyperthyroidism treatment can actually initially worsen ophthalmopathy?
Radioactive iodine therapy. This is so highly testable. RAI can cause a transient worsening of Graves' ophthalmopathy. It is a completely acceptable option for moderate hyperthyroidism, but you have to add the critical caveat that it leads to permanent hypothyroidism over time. That means lifelong levothyroxine supplementation for that patient.
Moving seamlessly into pregnancy endocrine logic now. Pause. What is the preferred anti-thyroid drug for a hyperthyroid patient who is in her first trimester of pregnancy?
PTU, or propylthiouracil. The rule here is incredibly strict. You use PTU in the first trimester because methimazole is associated with teratogenic effects early on. However, you switch them over to methimazole for the second and third trimesters to avoid PTU-induced liver toxicity.
One final physiological point regarding normal adaptations. Pause. In a normal, healthy pregnancy, what exactly happens to the patient's TSH level? The TSH slightly decreases, and that's because HCG weakly stimulates the thyroid. All right, let's aggressively rapid fire through the top cutoffs we just covered. Prolactinoma over 200, polyuria over 3 liters, and max 3% saline correction of 8 milliequivalents. Now, since we are out of visual space, let's do 2 final audio-only rapid-fire checks to lock in the rest of the endocrine axis. Ready? A patient is in DKA. What determines when you can switch them from an insulin drip to subcutaneous insulin? Take a second. The anion gap must be closed. Okay, last one. A patient with an acute adrenal crisis is in hypotensive shock. What is your immediate treatment? Think fast. It's IV hydrocortisone and rapid fluid resuscitation. Your biochemical logic has to be flawless on test day. I want you to consider how these pathways interact. Like, if a severe trauma patient's adrenal and thyroid axes are simultaneously stressed, how does that alter your golden rule of initial lab work? Keep those algorithms running in your head and trust your logic.